a big part of a dermatologist's job is making recommendations for over-the-counter topical products. There's a lot in the lay press about the FDA's safety and regulation of topical products and a tendency of a subset of people to gravitate towards natural products, presumably thinking that these products are safer. I started looking into regulation and safety data and realized there's a gap in formal training on this topic, so wanted to provide a guide to residents so they can be adequately informed.
In episode 65 of Dermatology Weekly, it's the Resident Takeover. Dr. Daniel Mazori talks with Dr. Sophie Greenberg about the selection of over-the-counter topicals to avoid potential adverse effects. This is Dermatology Weekly, the official podcast of MD Edge Dermatology, where we bring you conversations with leaders in the field of clinical and research dermatology, as well as the occasional Resident Takeover episode. Welcome to episode 65. I'm the voice of MD Edge Podcast's Nick Andrews. We begin episode 65 with clinical management guidelines for rosacea. Patients with rosacea should receive treatments based on the phenotype and the specific symptoms that those patients present with. This is instead of being assigned into artificially distinct subtype categories, which was previously practiced. The guidelines were published in the Journal of the American Academy of Dermatology. This update comes from the National Rosacea Society Expert Committee. It is based on a review of evidence and a follow-up to the classification system for rosacea that was updated back in 2017. That system recommended classification of rosacea based on phenotype. Dr. Diane Thibodeau is a professor of dermatology and associate dean of clinical and translational research at Penn State University. She spoke to MD Edge about the guidelines. Dr. Thibodeau emphasized that patients should not be classified as having a certain subtype of rosacea because many of them have features that overlap more than one subtype. Dr. Thibodeau added that clinicians have an opportunity to recognize that the symptom complex of rosacea differs widely, and treatment should be selected to address the symptoms experienced by any particular patient. She noted that this is particularly true with regard to ocular rosacea. She also noted that the clinical manifestations of rosacea are so varied that it calls into question if all of these are actually just one disease, rosacea, or if the manifestations represent localization of a reaction pattern to a multitude of stimuli that can obviously vary. The focus for the new guidelines is symptomology. Without definitive lab results, it is essential that the clinical diagnosis takes into account both the physical exam and the patient history. In the journal article, the authors summarized the management options and recommendations from a 27-person committee of experts. In the article, they also recommend accounting for patient perception and responses that they get to their appearance. Clinicians ought to note the effects that this has on the patient's emotional, social, and professional life when they're making a decision. Therapy will often require multiple agents, such as topical and oral agents for inflammatory papules, pustules of rosacea. If it's insufficient, adjunctive therapy with oral antibiotics or retinoids may be option, though the latter requires prevention of pregnancy during treatment. The authors also discussed pharmacological treatments for facial erythema and flushing, with all of these drugs organized in tables according to symptoms and their levels of evidence and effectiveness. The authors also noted the success with two types of laser therapy despite limited clinical evidence. Those types of laser therapy are pulsed dye and potassium titanol phosphate as treatment for telangiectasia and erythema. You can find the original journal article as well as our article by clicking the link in the podcast notes. And we now move to a review of physician salaries. In a survey of docs between October 2019 and February 2020, dermatologists reporting having the third highest salaries in medicine behind gastroenterology and at number one, cardiology. The survey was conducted by Medscape, who is owned by the same parent company as MD Edge. The results were finished before the outbreak of COVID-19, but even before COVID-19, it appeared as if dermatology earnings were down a bit from the previous year, from $419,000 per year to $411,000 this year. The average income for all specialists was up 1.5% from $341,000 to $346,000 per year. Dr. Joel Greenwald is an MD and the CEO of Greenwald Wealth Management in Minnesota. He told Medscape that specialists are having more trouble financially right now as a result of COVID as compared with primary care physicians. Dr. Greenwald said that this is because specialists are dependent on elective cases, which of course cannot be addressed via telemedicine. 65% of dermatologists believe that they are being fairly compensated, which is an increase of 4% from responses back in 2015. Other questions in the survey included if physicians would choose becoming a doctor again or if they would choose the specialty that they chose if they had to do it all over again. 76% of dermatologists said they would become a doctor again, and 95% of all dermatologists reported that they would indeed apply for a dermatology residence and become an attending again if they could. Only oncology and orthopedics had higher rates in that area. Dermatologists also reported the most challenging part of their job is difficult patients, followed closely by too many rules and regulations. You can read the entire results of the Medscape survey by clicking the link in the podcast notes. And finally, today, we're going to check in on the COVID-19 pandemic. The New England Journal of Medicine recently published the highly anticipated results of a clinical trial of the antiviral drug remdesivir for patients hospitalized with COVID-19. The FDA issued an emergency use authorization following results which appeared to show that remdesivir shortens disease course among patients who are hospitalized. The study, called ACT 1, is a randomized placebo-controlled double-blind trial. In the trial, researchers randomly assigned 1,063 patients who were hospitalized for COVID-19 at one of 73 sites around the world, 45 of which were in the United States. 49 patients in the trial group and 53 in the placebo group discontinued treatment due to withdrawn consent or an adverse event. 27% of patients had a pre-existing condition and 52% of patients had more than one pre-existing condition, the most common of which were obesity, hypertension, and type 2 diabetes. Okay, let's go through some of the data from Act 1. Patients who received remdesivir had a median time to recovery of 11 days, compared with 15 days in the control group. These data are statistically significant, with a 95% confidence interval range of 1.12 to 1.55 and a p-value of less than 1/1000th. Mortality appeared lower in the trial group. However, these data did not achieve statistical significance, with a 95% CI range of 0.47 to 1.04. By 14 days, the Kaplan-Meier estimate of mortality was 7.1% in the remdesivir group and 11.9% in the placebo group. MD Edge is covering COVID-19 as well as how the virus and the disease have dermatologic manifestations and how the pandemic is impacting the field as a whole. You can read all of our coverage, including the full results of Act 1, by clicking the link in the podcast notes. And that's what's new in dermatology. When we come back, the residents will be running the show. If you're a resident and you have an idea for a show topic for the resident takeover, email us and we'll make that a priority at podcast@mdh.com. Or if you're an attending physician and or educator and you have a topic that you think derm residents ought to know, you should email the show as well. The email address, again, is podcast@mdh.com, and you can follow us on Twitter @mdhderm. Derm Weekly. We'll be right back. Welcome back to episode 65 of Dermatology Weekly. It's time now for the Resident Takeover.
Today I'm talking to Cutis Resident Corner columnist Dr. Sophie Greenberg about her latest column on over-the-counter or OTC products in dermatology. Dr. Greenberg is a dermatology resident at Columbia University Medical Center in New York City. Thank you for joining me today, Dr. Greenberg.
Thank you for having me.
So I wanted to start off by asking you what inspired you to write about OTC products in dermatology.
So a big part of a dermatologist's job is making recommendations for over-the-counter topical products. There's a lot in the lay press about the FDA's safety and regulation of topical products and a tendency of a subset of people to gravitate towards natural products, presumably thinking that these products are safer. I started looking into regulation and safety data and realized there's a gap in formal training on this topic, so wanted to provide a guide to residents so they can be adequately informed.
I think that's great and really important. Something that was interesting to me that you wrote about in your column was how incorrectly selected OTC products can cause or exacerbate a skin condition or even result in systemic toxicity. So I was wondering if you've seen any adverse events in your patients from over-the-counter products.
I definitely have. We see a lot of allergic contact dermatitis, which is a allergic reaction to ingredients in topical products. I often see eczema exacerbated by incorrect selection of topical products, like the wrong type of moisturizer or choosing an irritating product. And acne that's exacerbated by choosing comedogenic topicals.
Yeah, those are really good examples. I think whenever you see an acne patient, going over all the products that can be comedogenic versus non-comedogenic, and sometimes can be very time consuming because there's so much out there and it's hard to decipher and go through all of that. So I've definitely seen that in my patients too. And certainly allergic contact dermatitis as well. I don't think I realized before dermatology residency how certain topical antibiotics can really bring that out in patients. So that's something that I always try to counsel my patients about.
Yeah, that's a really good point too.
Something I didn't know about before reading your column is how the FDA categorizes over-the-counter products, with each category subject to a unique set of regulations. What categories are relevant to dermatologists?
Yeah, it's a little confusing how they regulate it, but I would say the four major relevant categories are drugs, which includes both prescription and non-prescription medications. The second one would be cosmetics. Third is soap, which is a category all by itself. And fourth is dietary supplements.
Yeah, I found it really interesting how soap is its own category. But I guess before we dive into that, since you mentioned drugs first, what over-the-counter products fall into the drug category, and how is this category regulated?
So drugs include things like topical steroids, antibiotic ointments, acne treatments, antifungals, and sunscreens. And most of these products were previously available by prescription only, but became available over the counter after sufficient post-marketing safety information. So once a company applies for their drug to become available over the counter, and it becomes accepted as over the counter, the monitoring relies on reporting from healthcare professionals.
Do you know if the FDA is currently reevaluating how it regulates any products in this drug category when it comes to over-the-counter?
Yeah, so a big area in flux is how chemical sunscreens are regulated, which is in light of data demonstrating serum levels of these chemicals in humans above the FDA limit for drugs that are exempt from further testing for carcinogenicity, reproductive, and developmental effects. So I think in the coming months to years, regulation of chemical sunscreen will change.
Yeah, so we'll have to stay tuned as far as that goes.
Yeah.
The second category that you mentioned is cosmetics. Can you tell us what products fall into this category and how they're regulated?
Yes, so cosmetics includes moisturizers, cleansing shampoos, deodorant, makeup, perfume, and hair coloring agents. The FDA prohibits use of 11 categories of ingredients in all cosmetics. They encourage manufacturers to perform safety testing and have the legal authority to inspect facilities, but does not require approval, testing, or disclosure of safety data prior to products going to market. A lot of patients and lay public have expressed concerns over the safety of over-the-counter products, especially since regulation varies across the world.
Yeah, I can see how that could be concerning to consumers. And another layer to the cosmetic category would be imported cosmetics. So do you know if the FDA regulates imported cosmetics and if there have been any specific issues with these products?
Yes, so they do have the authority to regulate these imported products, but how this enforced is less clear. There have been cases of mercury poisoning from bleaching creams imported from Mexico, resulting in catastrophic neurologic damage for several patients, mostly in California. Clobetasol has been reported in products sold over the counter in the US, and I've actually seen this myself both in clinical practice, had patients with horrible adverse cutaneous effects from improper use of these products. And I have found these products on the shelves here in New York City, which I did report to the FDA.
Wow, good for you. That's really scary. Fortunately, I haven't seen anything as catastrophic as the neurologic damage that you mentioned being reported. But like you, I've seen patients who have had cutaneous side effects from bleaching creams that contain clobetasol and coming in with uneven skin tone as a result, or atrophy, stretch marks, telangiectasias. So I think that it's really important to be vigilant about that and educate our patients.
Yeah, I agree, because when we prescribe it, we have a chance to counsel patients on how to properly use these. But the fact that people can purchase them over the counter is very scary.
Yeah, I can think of a couple of patients of mine who unknowingly were using clobetasol with outbreak for years on end on their face, for example, which is a part of the body that we would even think twice about putting clobetasol on at all, depending on the clinical context, and likely never for years without breaks. So it's really a big, scary world when, these things aren't as regulated as we would like them to be, even if we're the ones as prescribers regulating them.
I know, it's horrible, and that changes their life to have something like that on their face.
The last two categories that you mentioned are soap, which we alluded to briefly, and dietary supplements. So could you tell us how these two categories are regulated?
Yes, so each of these are regulated as their own category. Soap falls all by itself and is defined by its ingredients and its intended purpose to be used as a cleansing agent. And dietary supplements are tricky. The FDA is responsible for evaluating safety and labeling of products before marketing and taking action against any misbranded products, but they don't directly test. Clinicians can refer patients to third-party agencies that verify ingredients and test for contaminants, such as NSF International or United States Pharmacopoeia, since there have been reports of supplements not containing the ingredients that they said they contain, or containing toxins or potential allergens. For example, there have been reports of walnuts being found in some of these products that were labeled as nut-free, which is potentially dangerous to patients.
Thank you so much for sharing all that information. I certainly didn't know as much about how over-the-counter products were regulated by the FDA and even categorized. So that was really helpful to go over.
I'm happy. Thank you.
The other part of your column that I really liked were the various resources that you included for dermatologists to familiarize themselves with over-the-counter products. And I've actually used some of these resources since I've read your column. So I was wondering if you could tell us about some of the websites and apps that you recommend.
I'm really happy to hear that you found it helpful. The FDA's website has more detailed information. You could look at my citations for specific pages that I found useful. To learn the ingredients of specific products, I refer to the Walgreens website, which lists ingredients of each product that they sell, or the Environmental Working Group, which has a program called Skin Deep, which maintains a database of more than 85,000 personal care products. You can access this through their website, or even better, using their app on your cell phone called Healthy Living, where you can scan a product's barcode and it'll pull all of its ingredients along with a gross safety rating.
So it was that Healthy Living app that I found really cool. I downloaded it the other day and I just started scanning all the barcodes in my medicine cabinet and just like shelves throughout my apartment. And it was really interesting to read up on them. So I think that's a really great resource, whether you're a clinician or a patient. It's just incredibly handy, and you can use it at home. You can use it in the store. So I think that was the one that really caught my eye and that I've enjoyed using.
I'm glad you love it. It's such an awesome resource.
So yeah, thank you so much for sharing that. What about textbooks? Are there any that you found helpful when it comes to learning about over-the-counter products and their ingredients?
Yes, so Wolverton's Comprehensive Derm Drug Therapy is a great initial resource to learn about the mechanism, efficacy, pharmacology, and side effects of specific ingredients, including hydroxy acids, shampoos, cleanser, sunscreen, insect repellents, and topical antioxidants. And then, of course, allergic contact dermatitis is a whole other topic in and of itself, but I do love Fisher's contact dermatitis for that topic.
So aside from websites, apps, and textbooks, do you have any other tips that you would share with dermatologists in terms of how they can become familiar with over-the-counter products?
Yeah, try different products on yourself. Then you get personal experience and are better able to address patients' concerns about tolerability, greasiness, how things rub in, sunscreens leaving a white cast, cleansers being too drying. You can get samples at conferences or purchase different products each time you restock your own supply. Another way would be to scan the aisles of your local pharmacy, and you can see what products are available and know what's out there when you're making a recommendation for patients.
I think that's great. I couldn't agree more. I remember my first year of residency, I was recommending an over-the-counter moisturizer that a lot of my patients came back and told me burned and stung. And then I went out and I bought it myself and I tried it and I was like, oh, right, that it really does burn and sting. So I couldn't agree with you more that I think, to whatever extent you can use yourself, your own skin as a canvas to test products on, it's incredibly helpful because it can just inform the way that you recommend and counsel your own patients about it.
Yeah, I couldn't agree more.
So with that, I want to conclude by saying thank you again for sharing all this information with our listeners. I think that, like you said, over-the-counter products are incredibly prevalent in dermatology, and there's never a bad time to learn more about them, perhaps even more so during the COVID-19 pandemic when patients may be relying on over-the-counter products more than prescription products because they may just not have the same access to a dermatologist. So I think that this is a good time as ever, if not better, to start learning about this or learn more. So thank you again for sharing all of this with us.
Thank you so much. Thanks for the interview.
And that's a wrap on episode 65 of Dermatology Weekly. I am Nick Andrews. Let's get to this week's credits. Dermatology Weekly is produced by MD Edge. The peer-to-peer portion and the resident takeover portion of Dermatology Weekly are produced by Melissa Sears. The news portion is produced by Elizabeth Meshkati. All MD Edge podcasts are produced by the editor-in-chief of MD Edge and Medscape, Dr. Ivan Oransky, as well as MD Edge executive editors Kathy Skarbeck and Mary Ellen Schneider. Multimedia editor Terry Rudd, and our social media producer is Kyla Clark. Derm Weekly is edited, engineered, and produced by Tyler Mundek. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.